Hello, everyone, and thank you for inviting me to present to you in your reflections on deafblindness, specifically in the context of definitions and terminologies. I will talk to you today on behalf of the members group of the Deafblind International and World Federation of the Deafblind Working Group. I'll explain a little bit more about that in a moment. And let's get started. So, the members of the working group came together earlier in 2023. Our working group is currently made up of Saskia Damen from the Netherlands, Meredith Prain from Australia, Henriette Hermann Olesen from Denmark, Lucia Darino from Spain, Helle Bulland Selling from Denmark, and Mirko Bauer from Switzerland. We've been meeting more or less as a complete committee over time, but there's always somebody missing somewhere. But basically, it's an ongoing effort for us to work towards a global definition of deafblindness, and that is what I will be speaking about a little bit more today. Now, trying to define deafblindness is not a new adventure. Many of you yourselves have been involved in this, and so I want to walk you through a little bit of some of the historical components because they are all playing together in where we are now. Some of you may be familiar with the work by Lagati from 1995, who wrote a few reflections about whether, for example, the word deafblindness should be hyphenated or not. What I specifically like about this article is that he acknowledges that we are in a situation here where language matters, because hyphenation is not necessarily an issue in languages like French, whereas in German, for example, that is a question. You can hyphenate or non-hyphenate. And so sometimes terminology needs to be considered in the context in which it is created. Given that we now have a majority of the research literature that is published in English, of course, this is an issue that touches all of us if we are communicating internationally, much like we do today. I've written a bit about this myself as well. We've conducted some surveys with people that are working in the field. This also included a few people with lived experience at the time. Dual sensory impairment is an interesting term in my world simply because it is more easily digestible in the context of working with older adults. It is less threatening to people with acquired impairments. I find it also interesting that in my own Canadian context, for example, some organizations will have their own creative ways of how they spell the word deafblind. The CNIB has avoided all of this together by simply capitalizing the word all the way through, so there's no question about whether there's capital letters or not. So there are different solutions to this problem. One of the reasons why I was invited to speak to you today has to do with our efforts to develop the ICF course sets for deafblindness. I will also come back to this a little bit more later in detail. But for those of you who are not that familiar with the ICF, most people understand it as a framework that really allows us to view any given health condition, how it interacts with different body structures and their function, how it influences activity and participation, and how these variables are then further influenced through environmental and personal factors. So if we use deafblindness as an example, it does have a code in the ICD in 2021. This code is for dual sensory impairment, given that it is not the cause of any single disease. And so if we look at something like assistive technology, which would be considered under environmental variables, we can see how it would influence communication, for example, which is considered part of participation. And so you can frame and view more globally any aspect of a biopsychosocial model and how to integrate deafblindness into a perspective of this kind. If you now look at starting points for definitions, if we focus specifically on eligibility criteria for services, this is really the traditional medical model of how most definitions have worked, and they originate really within body structure and with body function. if we look at functional effects of deafblindness, and we're now looking more into the psychosocial model of disability, we're really more exploring the effect on activity and participation. However, another aspect that I want to point out here is the self-reported and the identity-based approach to defining deafblindness. And now we are introducing a focus on lived experience, which is really much more connected to personal factors. Now, I don't need to introduce the Nordic definition in this context. You're all very familiar. It is simply, it's simple and elegant. And I think because of its simplicity and elegance, it has gained lots of popularity. It is represented on the website of the World Federation for the Deafblind. It is also in context mentioned and expressed within the information available on the webpage of Deafblind International. So here is a global and common starting point in terms of how a definition could be used and could be useful. Many of you will also by now be familiar with the Dutch functional definition of deafblindness. Now here they're taking an interesting step where they're creating categories. And we're looking at 3 specific groups: the congenital hearing and vision impairment group. This specifically, of course, is important in the context of working with children, working in the context of education, but also in terms of lifelong needs for individuals with congenital hearing impairment, since the deafblind itself does not necessarily threaten life expectancy. We've got a category for acquired hearing and vision impairment. Many of the adult onset groups fall here, or we're looking at impairments that develop after the acquisition of language. So that now is less, it's a little bit more difficult to figure out which diseases we're looking at, because here becomes a little bit less predictable what we might be after. And then, of course, we're looking at the age-related hearing and vision impairments. This is the domain where I do most of my work, looking at older adults that are living with impairments that developed linked to aging. Even though I very much enjoy this division in concept, of course, it leaves us hanging with a couple of marginalized groups that maybe belong to 2 of these groups, or where there's one impairment that is congenital and another one that is age-related. And so it doesn't really allow us to go into that level of subtlety. I've come across a different approach to definition in Ontario at the Rotary Cheshire Homes, where the beginning of the definition is really based on the state of hearing, because it is based on this level of hearing that we know more about the communication modality. And so here the 3 categories that are used relate to whether the individual is born deaf and then falls into any of the 3 categories of visual impairment that may be present. And here, likely, the person will be culturally deaf and use a sign language. The second category looks at individuals that are born hard of hearing, because that will likely influence their mode of communication. They may or they may not be verbal. They may or may not have learned how to use spoken language. And that may also in part be influenced by their level of vision. And then the final group are those that are born with normal hearing and may therefore choose completely different or very standard and normal ways of communicating. And this is also where, for example, the older adults would fall in, that are born with normal hearing, that are also born with normal sight, and then develop impairments later on. But this now opens the door a little bit to some flexibility within the severity and the time of onset. What goes with this approach are definitions that are based on communication modality themselves, specifically whether we're looking at receptive and expressive communication, and whether individuals are fully visual through visual language or also tactile languages, whether they're fully auditory or fully oral and fully sign in terms of expressing themselves. But you can see already that it gets tricky. For example, protactile is not in here. The tactile modality is not considered in this model. And of course, for a very specific part of the deafblind community, that is their principal way of communication. If I look at definitions in my own context within Quebec here in Canada, it gets very interesting because sensory rehabilitation in Quebec is part of the provincial medical care system. This means that any kind of services are provided at no cost for individuals that are eligible. This is where criteria are, of course, important for medical eligibility. And then there is great variability across Canada because health falls under provincial jurisdiction and is not federally regulated, which means from one province to the next within Canada, you can have very, very different levels of care and service provision that is possible. Specifically for vision, our eligibility criteria relate mostly to acuity. And so if we're looking at visual acuity that is 621, or if it is 618 or less, specifically with individual with a progressive disorder such as macular degeneration, they're eligible to receive any kind of services or receive devices. The same applies to a definition based on visual field, residual visual field of less than 60 degrees, either horizontal or vertical, that include the fovea. And finally, if we have individuals that have hemianopia. So the eligibility criteria for vision are based entirely on a medical model here. This is a bit mixed in hearing, where we now look at detection thresholds in audiograms across 4 frequencies. And now we're introducing more complexity by looking at the age of the individual. Children are automatically eligible for services if language development is threatened. For youth, the focus here goes into the eligibility for accessing education, also for employment, and so the thresholds are a little bit more relaxed. But what is very interesting and somewhat progressive about hearing in this context is that any individual, irrespective of age and degree of hearing loss, if they have experience of a functional limitation due to their hearing loss in any situation, are eligible to services. Not necessarily devices, but services. Whether this may be a social worker, maybe this may be a psychologist, a counselor, it may be services to facilitate communication strategies. So here we actually have an aspect in the definition that is purely functional in order to cross an eligibility threshold. When we combine these 2 eligibility criteria, we end up with our criteria for dual sensory loss in Quebec. But what's important here is that these categories, according to acuity and visual field and the audiogram, are specifically designed for eligibility for devices. So here you have to cross a specific threshold in order to fall into one of the boxes of eligibility. For services, however, there is a little bit more flexibility, and you can sort of perceive a bit of a gray zone across these regions here where the lines end. Conceptually, I call this our dual sensory space, or our, the reason I put this figure in here is because it is gradual. It turns out life, we often force things into crossing a line. I am not sure that this is necessarily always useful. And so we could view this dual sensory space as more of a continuum, if you want. But what is also interesting here is that we could replace these axes with any measure of vision and any measure of hearing. And they could be functional measures, they could be observational measures, they could also be questionnaires or self-reports. I think that in the end, the way we place people in this space will require a little bit of flexibility. The World Federation for the Deafblind has used something similar. They've chosen an approach that is again categorical about whether people are hearing, hard of hearing, or deaf, sighted, partially sighted, or blind. And so, again, we fall into which of these areas overlap, and that is where you end up being considered deafblind. The World Federation has also tried other ways of visualizing these definitions and these categories, but here is the hook. we are still in the world of categories, and that means some people are in, some people are out. And I think that part of our efforts right now is to find ways of working around categories, or to smoothen the edges, if you want. As part of this exercise, of course, context matters. I've taken an example here from our friends in the States, where we're looking at definitions that are used in the context of education. So we're looking at children with deafblindness, whereby the definition here tells us that there are severe communication and other developmental and educational needs. And of course, that is relevant in the context of education for parents. But this context changes when you look at older adults. This here is an attempt of the World Federation to give us an overview of the different possibilities, whether you are born without any sensory function and you live into old age as a deafblind person, whether you're born with one loss but you are then developing the other, and this could be hearing or vision, or whether you're born sighted and hearing and you develop deafblindness over time. Here, the time of onset is flexible. There should be a bit more flexibility respected in the severity of things, but there's only so much you can do within one figure. But it is an attempt that I very much appreciate about showing the complexity and the heterogeneity in the population, and that explains why this is so complicated. So we've been exploring what I'm going to call the dimensions of deafblindness. In the medical model, the medical dimension, really we're focusing mainly on eligibility criteria. Things like visual acuity, visual field diameter, pure tone averages. There are other more subtle measures like contrast sensitivity or speech and noise comprehension that may functionally actually be more important or more devastating if they are impaired, simply for things like comprehension of speech or recognition of faces. But they can be expressed in a numerical model, so they don't necessarily have to have a qualitative dimension to them. If we move further over into the psychosocial model, we're now looking at function. And functional difficulties can either be self-reported, but they can also be observable, but it's not necessarily on a scale from 1 to 10. Finally, I want to come back to the idea of self-report and the personal dimension. This links us to the fact that we need to consider the identity of the individual and their lived experience as a person that is living with combined vision and hearing impairment. So where are they themselves on their own definition of who they are and what they are? This is a sentence that I picked up in the work of Alana Roy during her PhD in Australia in Melbourne, where one of her published works says, when engaging with people who are deafblind, being deafblind, it's who we are, not what we are. And so this idea of identity is not necessarily reflected in any of the measurements that we've been exploring up until now. So what the DBI WFDB working group is currently working on is to work towards a global consultation on this topic. There's a survey that is currently under development and that will arrive in your email inboxes within the next little while. I hope. We're currently working on ethics approval for this project. It will try to be as globally accessible and representative as possible. But I want to give you a reflection, and this is now still very early because none of this is crystallized enough to be really presentable yet, but I want to give you sort of a look into this reflection. We could look at a triangular model that will consider the medical, the functional, and the personal dimension together. So let's say we have a person who has no light perception, whose pure tone average is about 60 decibels hearing level across 4 frequencies. Here is a definition of their medical placement within the model. It could very well be that this person is a proficient Braille reader, is well adapted to home and work environment, is also a proficient speech reader, and manages well with 2 hearing aids. So now the functional impairment may actually not be as severe as what is expressed within a medical model. However, when you then speak to this person, they consider themselves blind and hard of hearing and not deafblind. Now, how we express this, how this then gets formatted, you can see that I have creative ideas, on how we might be able to create a three-dimensional version of a definition. But like I said, this is in early days and we don't really know yet exactly where this is going. Now, I've been asked today also to include a little bit on the role of the ICF and our core set work in this context. The goal of the core sets is really to identify the most important aspects, dimensions, domains of deafblindness according to the consensus that we reach right now with individuals that have lived experience. This includes the persons with the impairment as well as their family members. We've also consulted with experts in the field of health and social services and support systems. And we have the perspective of researchers here as well. And the consensus of those three groups is scheduled to happen over the next coming months to be presented on October 9th. So we will have more news on this later this year. What we do now is we can explore if the aspects that are reflected in our definition, the global definition, are the same aspects that emerge from the ICF model. And let me explain to you how this could work. What I'm showing you here, one of our octopus graphs, is the distribution of the proportion of codes in the ICF that have been used by individuals with lived experience when they're asked about how deafblindness affects their body structures, function, activity, participation, and which environmental and personal factors influence their ability to function. As bars are wider, it means that there are more codes that were used in the transcription of this information. So things that are here frequently, that are expressed more frequently, will have bars that are wider. I'm talking about frequency. I'm not really talking about importance, because the importance of this is difficult to judge through frequency. But frequency gives us a hint in terms of how many aspects are actually impaired. The reason this can be useful is because we can then do the same exercise looking at the research literature and then compare if there are differences in the patterns of what is researched versus what people want us to actually look at. I'll give you an example. The most frequent codes expressed by people with lived experience in terms of activity and participation centered on mobility. But it turns out mobility was by far not the most researched aspect of activities and participation in deafblindness. Instead, the majority of the research literature looks at learning, communication, and interpretation and interaction and relationships. So interpersonal relationships and interaction. So here we can definitely and clearly see that there is a discrepancy with what we are conducting in terms of research versus what people value when they have lived experience. In a similar way, when we look at the result from our expert survey, and I know that many of you in the audience have actually answered our expert survey, the same topic emerges when we look at mobility. The majority of expert opinions looked at communication and community and social and civic life. Mobility was part of it, but it was not among the top three. And so I thought that that was really interesting to see how even the people that work with individuals that have lived experience don't necessarily judge the frequency of topics in a similar way. You can see from the complexity of these figures that there are many other aspects where we can make these comparisons. You can see, for example, vast differences in terms of the environment category, but that is all part of our exercise right now to come to consensus. I will not take you further down this rabbit hole today. So you may ask why we are working on a global definition. Many countries don't have a definition at all, and so we're actually trying to provide a starting point, an ideal case starting point. It turns out that many existing definitions have a very specific purpose and are then limited in what we can actually do with this definition, and so we're trying to provide a larger perspective on this. And we're also trying to be as optimistic as possible and create a gold standard definition that lets everyone strive to something more idealistic or more optimal. Thank you for your attention today. I am looking forward to having a bit of discussion on this. All thoughts are welcome. And if you want to know more about the Consensus Conference, I invite you to visit our website on whoisdeafblind.org, where most of our results will be posted after October when the Consensus Conference is over. Thank you very much.